Hello and welcome to another edition of Professor Speaks. Today we're going to be talking about the differences between hospice and palliative care. But before we do, make sure you hit the subscribe button and hit the little bell for notifications. Hello and welcome. My name is Alex Hernandez. Alongside me as always is Dr. Craig Stern. And jumping right into it, this topic came up when we were informed of the former First Lady Barbara Bush had passed away, and what I wanted to talk about was the difference between hospice and palliative care. Can you help the listener or
Sure.
the viewer to define the differences between the two?
Sure. Number one is we're not talking specifically about Barbara Bush, although we give our sympathy to her family.
Of course.
The issue here is the following. People come to a point in their lives where there is nothing further that can be done, or that their death is imminent.
Right.
When the decision is made within a 6-month period,
Okay.
that their life will end at some time within the 6-month period, then they and the family are given some options about going into hospice care, which means that they will be maintained, they will be kept comfortable, but no heroic measures will be taken. There won't be any surgery, there won't be any procedures, there won't be anything like that. Palliative care is kind of like that, but in palliative care, it's at the time that someone is going to make a diagnosis that a person has a short term left in their life. At that point, then there's a decision made that they are going to be kept comfortable, that they won't have any heroic measures, etc. So it's a bit of a distinction. In the case of hospice, it's made after the fact.
Right.
In the case of palliative, it's made at the time.
And this hospice and palliative care, is that usually only with the older population, or can it be extended out to? I guess because the reason why I bring this up is because there's been a lot more chronic illnesses being diagnosed at a younger age than ever before. Are we seeing a larger population being exposed to hospice and palliative care?
Yes, there is. And it doesn't just deal with elderly people. It's not relegated to any particular age group.
Right.
It has to deal with issues that deal with your life and whether your life is going to be concluded within a period of time. I would say one thing. I've had experience with this, while not being a total expert in it, meaning doing it every day, day in and day out.
Right.
But I've been exposed to it a good deal through cancer, chemotherapy, and others, and my own mother. And I can tell you that there is a certain honor and courage that people have when they know that they have a short time to live, and the fact that they have made that decision and what they're going to do.
Right.
These people are very courageous.
Right. And going more detail about hospice and palliative care, what kind of medications are usually used for that kind of care?
Yeah, that's an important point, because as I've indicated, palliative care, hospice are not about surgery. They're not about doing some heroic measures.
Right.
They're not about doing some issues with regard to surgery or otherwise.
Right. I can imagine it's a lot of painkillers that we hear about.
It is.
Yeah.
It is. And the bottom line here is, and fundamentally, everything rests upon the fact of keeping the patient comfortable. You do not, absolutely do not, want someone to be in stress, someone to be hurt, someone to have enormous pain. That's not the goal.
Right.
So there is a trend of things. Number one, of course, is pain management, to ensure the fact that they're not in pain, partially because a good many of the patients who are involved are cancer patients or end-of-life kind of issues. But it can be people who have significant cardiorespiratory disease, where they have significant COPD, where perhaps they have congestive heart failure and other things, so that there is a limit to what's going on. You then also try and support the pain management with drugs that will support the pain management, meaning they're called adjuvants, but you're dealing with things that will support it, such as people who have a pain management, and frequently with opiates, will be constipated, so you have to try and help them so they're not dealing with severe pain or discomfort over that.
Right.
Potentially they're also depressed because it is not a happy time, so they may be on antidepressants to deal with it. The antidepressants try and help because you want to make them comfortable, and if depression is the only thing they can see, what you're trying to do is to address that. All of the medicines that we're talking about really have to deal with comfort. So anything that will keep the person comfortable and the rest. There are patients who have significant pain, that bone pain or otherwise in cancer, who are put on morphine drips and things like that. The ultimate goal is not to kill anybody. The ultimate goal is just to keep them comfortable. So in their last minutes, days, weeks, months of life, they're not in enormous pain. That just would be horrible to put them in that situation.
And I can imagine with medications that, as being an analyst and you yourself a doctor, you can see a lot of these claims that are coming in, a lot of the prescription claims that come in that we see on a daily basis, where you have a lot of complications with adverse drug interactions, or a lot of patients who are on 7 different medications at a time, that there could be complications with that. So the type of monitoring that takes place at a hospice care or a palliative care can be tremendous, can it?
Well, it can, and what you do is, once the decision is made, and it's made by the individual and the family, or the family if the individual is not able to make that decision, what is done is to make an evaluation of the patient's care. So you are evaluating, you're looking at therapies, for example, that may help to extend life or may help to prevent complications. Those drugs are no longer necessary. So for example, and only as an example, you may be on drugs like statins for cholesterol to lower your overall cholesterol. Well, there's no need to lower the overall cholesterol because the end point is already known. So those would be taken away. Other medications that don't keep you comfortable, whether they are relaxants or whether they are drugs for some sort of conditions, would be taken away. But then there's a very serious analysis which we have been involved with, where you're looking at drugs to treat high blood pressure, diabetes, thyroid conditions. If they're there and they were approved and they're FDA approved, then clearly you keep them. If they're not FDA approved and they're being used off label, meaning there's no indication that they would work or that you know what the risk is, they would be removed. But you have to look. If you need to control the blood pressure so that someone isn't in extreme discomfort because their blood pressure goes sky high, then you have to maintain that medication. In the case of diabetes, you may have to maintain the medication so that, in fact, their blood sugar is kept under some control, but you may remove some of them if they're trying to prevent cardiovascular disease or something, because the disease is already there. And so you're simplifying. The ultimate goal is simplify therapy, remove anything that is unnecessary to keep them comfortable, and that's a professional decision. You have to look and see what is going to keep them comfortable versus what is unnecessary, and remove that.
Right. And when you bring up these unnecessary medications, and you've also mentioned off-label medication, could there be room for experimental drugs? Like they've talked about, the cannabis oil or stuff that hasn't been exactly FDA approved.
Yeah, that's part of the discretion. There's no hard and fast rules. The World Health Organization, the WHO, has a list of drugs that are commonly used in palliative care. But so have some other groups that have done that. But it's a decision. If it's drugs that are experimental, in general they'll be removed, so that, because there's no reason to do an experiment or to try and give some medications that don't have some indication. On the other hand, If there are some medications that are keeping people comfortable, then there may be some decision about that. But that clearly is something, it's a professional decision. And then, of course, the family and the individual may have some involvement in that as well. It's a joint decision. Nobody is trying to be adversarial. Nobody is trying to be that. I think at the end of the day, people need to understand at the very base, hospice and palliative care does not mean, and I mean does not mean no care. It means there is care, but the care is very focused on keeping the person comfortable. Everything else that doesn't keep the person comfortable goes.
Right. Medications for chronic conditions. You mentioned it a little bit before with the diabetes and hypertension. Is there any other medications that are used for these chronic conditions?
Drugs for I'm not trying to pick on anything in particular, but just as a general way, drugs that are being used for skin conditions, anti-inflammatory drugs, those in general would be drugs that would be stopped. Drugs, for example, that are not maintaining the given organ in order to function would be stopped.
Right.
If a person has significant kidney disease and organ disease where the kidney is failing, then you would try and maintain whatever you could so that they were not in tremendous discomfort, but you'd probably remove medications for that, liver disease, etc. But because you're not trying to save those organs, now you're just trying to keep the person comfortable. So if it's purely just to save the organs, those medications would probably be removed. So this is a medication issue, a medication treatment, but it's not everything. So all of the potential for drug interactions, for issues with regard to adverse effects, etc., those in general would be removed because there's no need to try and manage someone through this at the time that they just need to be kept comfortable.
Right. And just kind of to wrap it all around and put a button on this, Barbara Bush, when she said that she was denying care, what exactly did that mean? Do you know? Do you know what?
I don't know specifically with Barbara Bush, but when people are healthy, they sign something called an advance directive. An advance directive is something that goes in the chart. It is their decision about what should be done for them if they are in a bad accident, if they're sick or otherwise. And it has things such as, I don't want heroic measures like I don't want you to do CPR in order to maintain my heart if I'm very sick or there's no chance that I'm going to come out of it. Things such as that I don't want to have some sort of surgeries, or I don't want to have anything like a code blue that would keep me alive if there's no chance that I'm going to deal with it. It is a patient's decision entirely for them to do. Certainly a healthcare provider would talk to them and say, you know, here's the issues, here's what your options are. And then it's the person's decision and their family's decision about what they do. When they have an advance directive, then that decision has already been made. It may be that after multiple things have been done, that they say, okay, we are in effect employing the advance directive when we don't want anything further to be done. Or they may, irregardless of having an advance directive, they may say, look, we've done everything you can do to treat the infections, to deal with my kidneys, to deal with whatever other organs are involved, and I've had enough. It's time to end that. And it's a personal decision. They or the family signs it, depending on how coherent they are. And as a result of that, then nothing further is done beyond what we've talked about. I don't think people know a lot about this. It's not something you probably want to know a lot about. You're right, it's not a happy subject. But I think we should make it very clear that the people who make this decision, if they're coherent, it's a very brave decision because you know what the end point is going to be, and yet you've made the decision that I am going to do this. And you have to look at that and say, that's pretty special. For families that do that, it's heart-wrenching. It's really difficult because you're looking at an endpoint and there is no other outcome that's going to happen. So it's not like, oh, someone's going to find something totally investigational, or that there's going to be some miracle that it's going to happen. This is not about miracles. It's not about that. This is about people making a very measured, very honest, very courageous decision about how they want to die.
Right. Well, that's it for our discussion today. And if you have any questions or comments, please feel free to leave them below. If you have anything to add to the discussion as well, please feel free to leave them below. And just to remind you to subscribe, hit the little bell for notifications. And we typically have new videos every Friday, but next week Dr. Stern is off. He's going to be in Boston for an AMCP conference. So if you're there, make sure to tell him hi and shake his hand. He's very friendly. And tell him that you saw him on YouTube. And we will see you in 2 weeks. Yeah.